Good afternoon and welcome to today's program titled A 2017 Preview, What's Ahead for CMS Policy and How Long-Term Care Can Position for Success. I'm Pamela Tabar, Content Editor for the Institute of the Advancement of Senior Care, or IASC. Today's program is sponsored by Omnicare, a CVS health company. So thank you to our sponsor and to our audience for giving us your time and attention today. Before we get started, we just have a few housekeeping details. Each window on your screen can be moved by clicking and dragging, or it can be enlarged and minimized by clicking the icons in the top right corner of each window. Please use the Q&A area to the right of the slides to submit a question at any time. If you cannot see this area, just click on the red Q&A button. To download a copy of today's slides and other resources related to today's topic, please click the links in the resources area in the lower left of your screen. If you have any technical issues during the program, just click on the yellow Help button and we'll troubleshoot your issue. A special note about CE credits. In order to receive CE credit for this program, you'll need to click on the green CE certificate widget at the conclusion of the program and complete the evaluation form. Please note that you must watch the webinar for at least 50 minutes in order to obtain a certificate. If you're watching the program as a group, please download the group submission form located in the resources list and follow those instructions. If you have any issues with this process, please don't reach out to our sponsor, as they will not be able to assist you in receiving a certificate. Also, please note that the CE credit is not available for the archived version of this webinar. The CE credit is available only for the December 7 live event. Finally, you also can tweet during today's webinar by clicking on the blue Twitter icon at the bottom of your screen. Simply click the Post and Authorize buttons to log into your own Twitter account and begin sharing automatically at the event hashtag IASKLiveWebinar. So at this time, it's my pleasure to introduce today's speakers. Cynthia K. Morton is a national expert on Medicare, Medicaid, and other public policy affecting long-term and post-acute care. Currently, she serves as the Executive Vice President for the National Association for the Support of Long-Term Care, or NASL, where she advocates for her members' interests. Prior to joining NASL, Cynthia served as the Vice President for Political Affairs at the American Healthcare Association National Center for Senior Living, or for Assisted Living, otherwise known as ACA-NCAL. Also, we have with us today Todd King. He's the Senior Director of Clinical Services for Omnicare. So thank you, Cynthia and Todd, for taking the time to speak with us today. And with that, Cynthia, the audience is yours.
Thank you, Pamela. It's a pleasure to be here today. I know everybody's excited to talk about what's going to happen next year because, of course, this is a preview. But first, let's just take a second to review what's going on right now because Congress is still in session. And while they're still in session, you never know what could happen. There are really three key issues as it relates to long-term post-acute care that are remaining in the lame duck session, as we call it. The continuing resolution is how the government is funding. You know, when you hear about the government being shut down because the funding was not authorized, well, Congress has got to authorize funding for the government as the current agreement is the government is just funded until Friday. We do expect the Congress to pass a CR, a continuing resolution as it's called, probably until the end of April of next year. Why? President-elect Trump has signaled that he would like to negotiate government funding, government spending when he's president with the new Congress. And so in deference to him, the current Republicans that are in control right now are going to pass a CR and have that negotiation wait until the new Congress. Probably more important for us is a bill that has been moving very slowly through Congress. It's called the 21st Century Cures. You most likely have read little snippets about this in local newspapers. It has broad bipartisan support. I think the House passed it originally back in 2015. It's been kind of poking around for a long time. The Senate, for whatever reason, just didn't want to get around to dealing with the bill after the House passed it a couple years ago. But this Congress is about to finish when we finish up the lame duck session. So any bills that have not been enacted in this Congress will die in December. So the Senate did take it up. They made a couple changes to it, and a version of it was shared with the House, and the House passed it by that wide margin you see on your screen, 392 to 26 the other day, and we expect Senate approval today. What's in it for us? Not a whole lot. The bill is mostly about having cures for diseases to be approved faster through the government, and more funding for NIH and FDA. That is really the big part of the bill, and it's a good thing. The only little pieces of significant consequence that really touch long-term post-acute care there are a few health information technology issues, and what that means is that Congress is beginning to regulate electronic health records. Just like they regulate almost everything else in our healthcare sector, they are now encroaching on that area, and that's mostly what the bill is about for us. And there's a few very minor Medicare pieces. And we expect the Senate to pass that bill today, and the President will immediately sign it. And there'll be big headlines that a big bipartisan effort was achieved by this Congress. Then one final issue that we may see before Congress is set to finish up either this Friday or a week from Friday, and that is value-based purchasing for post-acute care providers. Now, if you're a nursing facility provider or a skilled nursing facility provider, a SNF, you're saying to yourself, wait a minute, don't we already have value-based purchasing on us? Indeed, we have a value-based purchasing program. It only has one quality measure in it, and that measure is around rehospitalizations. That is in current law for nursing facilities. The Ways and Means Committee is looking at a bill, and we're waiting for it to be possibly introduced any minute now, and it would repeal that program for SNFs and in its place have a value-based purchasing program for 4 post-acute care settings, SNF, home health, IRF, and LTAC, and all 4 would be linked in some way. More about that in a minute. So with that kind of cleaning up what's going on right now, let's turn to next year because we're on the cusp of a very unconventional presidency. We had an unconventional campaign, and it's really going to be interesting to see what can happen next year and the other years of President-elect Trump's presidency. Now, he has come out with many health care ideas on his agenda. Repeal and replace the Affordable Care Act. You hear about that one all the time. Possibly modifying the law on the sale of health insurance across state lines. Health insurance premiums to be fully deductible on your tax return. Expansion of health savings accounts. Those 3 items could potentially be a part of a package of replacing the Affordable Care Act. Price transparency from all health care providers. Certainly in Medicare and to some extent Medicaid, we already have transparency. We know what the government pays us because we don't really like what it pays us in many cases. Provide block grants to the states for Medicaid. Now, I'm going to talk about this one in a little more detail in a later slide because that's really going to impact us in our sector. And then he has also talked about a regulatory review. In fact, I think he has said things like, for every 1 new regulation, let's get rid of 2 old ones. Well, I would really like that to be applied to CMS, wouldn't you? I'm excited about that, but, we'll kind of see. There's a lot to get done here. I'm probably missing a couple things on this slide here. Some of these points he has said he wants to get done in the first 100 days. Probably not possible, right? I mean, that's a lot to get done. So what is the priority? And as I look across his agenda and I think about what's out there, what we've been reading about, what I talk about to various members of Congress and their staff, I would say the three items here on the screen are the highest priorities. Obviously, repeal and replace of the Affordable Care Act. We've all heard about that. Medicaid, and you might be surprised that I'm not saying Medicare, but Medicaid. And then finally, tax reform. And I'm not going to talk about too much about tax reform because it's really beyond the healthcare area, and I have to admit I am not a tax reform expert. But what I do want to talk about is why we know the Affordable Care Act and Medicaid are going to be two of the hottest and highest agenda items for the Trump presidency. And I want to talk about those two priorities in the terms of the two appointees that President-elect Trump has nominated thus far to run HHS, Health and Human Services, and to run CMS, Centers for Medicare and Medicaid Services. So let's start with the first appointment he made just the other day, thankfully in time for this webinar. He nominated Congressman Tom Price, Secretary Designee of Health and Human Services. I know Congressman Tom Price. I have lobbied him over the years. He is a very thoughtful person, very knowledgeable about health care. He's an orthopedic surgeon by training, served in the Georgia State Senate, which is always good because when you're a state legislator, you receive some kind of sensitivity to Medicaid issues. He is a very conservative legislator. He is a Republican, comes from a very conservative portion of Georgia. He's in the Doctors Caucus, a Tea Party member, Republican Study Committee member. But beyond that, let's really think about him as a provider. He's a provider, a solo practitioner is really his point of view as an orthopedic surgeon, and he will take that provider point of view with him to be Secretary of HHS. In that role, he will oversee CMS, FDA, NIH, a whole host of other agencies. And his attention will be, pulled across many, many issues. He has been an outspoken critic of the Affordable Care Act, outspoken on the Affordable Care Act even before it was passed. And I think that is one of the reasons why he was chosen by Trump to run the secretary, to be the Secretary of HHS. So that shows you why repeal and replace of the Affordable Care Act is perhaps the highest health care agenda item. He has a good relationship with Speaker Ryan. He is close with Vice President-elect Mike Pence. He also, in his activity in the House, and currently he's the Budget Committee chair, he has authored some letters along with his House colleagues regarding the mandatory demo, comprehensive care for joint replacement, that was a little controversial, which was quickly followed up by CMS with another mandatory demo, the cardiac cath demo. He also has written a letter to CMS to talk about the requirements under MACRA. MACRA is the successor to the physician fee schedule and really moves it from fee-for-service to fee-for-value. So you can see why I'm saying, and I think it's obvious from the rhetoric, that the Affordable Care Act is a key agenda item. So let's turn to the CMS designee, Seema Verma. Ms. Verma has run the Indiana Medicaid program for Governor Mike Pence, so you can see the closeness there. And she currently runs a consulting company helping states submit 1115 Medicaid waivers. More about that later. Now, I don't know her, but just looking over her resume on her website, her provider experience seems to be very hospital-based, so a provider perspective as well as a Medicaid perspective. And it looks like the majority of her perspective and her experience does look to be Medicaid. So in my estimation, she is going to need a strong Medicare leader as, a deputy with her at CMS. So those are the two folks that we know of so far. They're going to be at the executive branch running the agency. And you can see why I'm telling you that Medicaid is a very high priority by the choice of the president of who he wants to run the CMS agency, because generally the previous administrators have all had the majority Medicare experience. Let's turn our attention real quick now to the legislative branch and talk about Speaker Paul Ryan. He is going to be very much a factor in what happens on health care and what happens on long-term post-acute care as well. He came to Washington many years ago really with his own personal mandate to rein in federal spending. That is his, I would say, chief interest in service in the Congress and to the country. And I like to show this pie chart to really help you understand his perspective. If you can see the pie chart, you can see that as a part of the federal budget, Medicare and Medicaid spending combined are 24%. That is a quarter of all federal spending. And so it's his view, and shared by many, that really going after what are called the entitlement programs, Social Security, Medicare, and Medicaid, are really the way to get at federal spending because that's where the money is. And putting Social Security kind of off the table for a moment, that's why there's so much interest in reforming. And keep in mind, reforming can be a code word for cutting, right? Reforming Medicaid and Medicare. So he has his own ideas that he put out earlier this year in a document called A Better Way. That is his agenda and the House Republicans' shared agenda. Just some highlights from that plan. They'd like to actually repeal CMI, the Centers for Medicare and Medicaid Innovation. That is a piece of CMS that was created by the Affordable Care Act, and the kind of the Silicon Valley of CMS, if you can even imagine that. It's the innovation unit at CMS that is creating ACOs, creating bundled care for payment initiative, creating CJR, and so you can see why it has caught some of the ire of members of Congress. Speaker Ryan would like to make pretty large changes to the funding of Medicare. He'd like to move it to a premium support program, which means seniors would be given a chunk of money to pay for their premium, perhaps through a voucher. Now, these changes would not happen anytime soon. They would not affect operators, providers, patients today. This is a very future plan that he has. He'd also like to move the eligibility age to 67, and indeed he supports block granting Medicaid or changing it to a per capita cap system, which I'll detail a little bit later. So are you seeing a theme here? Block grants are very much on the agenda for the new president, and they're very much on the plan for Speaker Ryan and the House Republicans. So this is an ambitious agenda, both for the president and both for the Congress. How will Congress do this? Well, they're going to use a budget rule that we call reconciliation, and you've probably heard of that before. And the word itself does not really help you understand what it means, but just kind of keep this in mind: it moves fast. Okay, it allows the Congress to move fast on something when they want to. It is, as I said, a budget rule that Congress imposes on itself, and it really allows measures to be fast-tracked. For example, in the Senate, if a particular measure meets the criteria to be in a reconciliation bill, it only takes 51 votes to pass it in the Senate. It does not need, for example, 2/3. And there's many technical rules that restrict what subjects can be covered in a reconciliation bill, but it can be used on tax reform measures, some health care reform, and it could apply to the majority of the Affordable Care Act. Now, the 115th Congress begins January 3rd. That is when we'll see all the new members come back to Washington, D.C., The president-elect is not inaugurated until Friday, January 20th. So I'm expecting, all of us Congress watchers are expecting some pretty early action on the Affordable Care Act, not necessarily repealing it, but we're thinking we're going to see some action perhaps early action on a budget resolution that would contain reconciliation instructions regarding repeal and replace. So it will be Congress laying the beginning groundwork for what they want to do on repeal and replace, and they're going to want to, be very symbolic for the country and show that they can act really quickly. Now, once President-elect Trump is into office, what will he face in dealing with the 115th Congress? I mean, it's not all going to be smooth exactly. You have in the House 241 Republicans, and you have 194 Democrats. So the Republicans are firmly in control of the House of Representatives. But, you do have factions of groups. You've got the Freedom Caucus, it's kind of like the Tea Party group. They don't want any extra spending, okay? And they could be a problem. It's Republicans. They could be a problem for the new president if he wants to push an infrastructure measure. Infrastructure, repairing bridges, building roads. That's going to take quite a bit of spending, and that could really meet opposition from the Freedom Caucus. There was many reports earlier, that because Speaker Ryan didn't come out and endorse President-elect Trump during the campaign, that could be a problem for him and his leadership in the House. But he's been reelected Speaker. He is firmly in control, and he's doing all the right things to control his caucus going into the 115th Congress. The Democrats in the House will mount plenty of opposition to Medicaid block grants and other issues, repealing, replace, Affordable Care Act, but they will not have much luck there because their numbers are small. So what could happen in the Senate for President-elect Trump? The Senate is really a different body, and for those of you that have come up to Capitol Hill to make advocacy visits, you know that the House is the people's house, and it's a little more raucous, but the Senate is the upper chamber, right? Much more serious. Certainly the senators take themselves much more serious. But you have a long history in the Senate at the Senate Finance Committee, where most of the issues that touch long-term post-acute care go. They have jurisdiction over Medicare, Medicaid. That committee works closely together, the Republicans and the Democrats. Long history of that, and we expect that to continue. So the Republicans are in control going into the new Congress, 52 Republicans, 46 Dems. We will have a new minority leader. Harry Reid is leaving, and Senator Chuck Schumer of New York will be the new minority leader. He is known as a deal maker, and I think he could have a smoother run than his predecessor with Majority Leader McConnell of Kentucky. And just a political note, these numbers in the Senate could change. We've seen two senators be asked up to Trump Tower in New York to talk to President-elect Trump. Who knows if some kind of administration job is being dangled before their eyes, and you never know if they may accept it and leave the Senate, and new ones have to come in and be appointed. So it's kind of a moving target at the moment. So enough about kind of all the context, and all the infrastructure. Let's get to what's hot for us, right? What are we going to be looking at as providers, as operators, as clinicians, administrators in the greater long-term care sector? Affordable Care Act. I think that's going to be on everybody's lips for a long time. Repeal could come quickly. As I outlined a few minutes ago, they'll be laying the groundwork in the budget resolution most likely, and we'll kind of see where it goes from there. But replacement is harder, right? I mean, they're going to have on their hands 20 million people that get their insurance through the Affordable Care Act, and you don't want to disrupt the market. You don't want people to go without insurance. Replacing is going to be harder to do. And I think a lot of time will be spent debating that in Congress. And, you know, even doing easy things takes a long time, sometimes months, sometimes years for Congress. And they know that they own this problem now, and they can't take the whole, 2 years of the Congress to replace the insurance. People are going to be, up in arms. So that's going to be an interesting thing to watch. Now, what piece of that Affordable Care Act repeal could touch us? And really at the moment, what we're watching for is, is the whole law going to be repealed, or will it just be the insurance parts of that law plus a couple other items? And I would say like one of those couple other items could be this CMI, the innovation unit that I mentioned. We could see some limits passed into law through the repeal, some limits placed on the scope, limits placed on the authority of CMI. Maybe they can't do these demos as fast as they've been doing them, or can't write them to be as expansive as CJR, for example, has been. That's where I think it could touch us. And CMI has authority over the Bundled Care for Payment Initiative, BIPSI, and that Model 3 is a post-acute care only model. So that's where it could touch us. And sometimes these big efforts become what we call Christmas trees, and lots of other pet projects from members of Congress are attached. And so that's where other issues that were not really germane to the Affordable Care Act could get attached. So that's going to be obviously a huge effort, consume a lot of oxygen, as we say. But let's look at Medicare, okay? And, every year we have Medicare reform, and it comes in two ways. It can either just come in the form of just flat-out cuts to Medicare, or what I call programmatic changes that change the policy, but sometimes that policy also has the effect of cutting funding, right? So we're not sure exactly what we're going to see. We do know for sure that from a Part A perspective in Medicare, we're going to see the successor bill to H.R. 3298, Medicare Post-Acute Care Value-Based Purchasing Act. As I mentioned earlier, this is this bill. We may see a draft any day now, but that bill will die with this current Congress, and it will be reintroduced in January with the new Congress. And this is an effort by the Ways and Means Committee to make value-based purchasing broader. They envision a program that links the 4 post-acute care settings, SNF, IRF, LTAC, and home health, and there would be several quality measures, and they would be actually the quality measures that are involved in the IMPACT Act. But these measures would be, for providers, would be connected to withhold of your payment update, and you'd have to earn back your payment update. I don't want to go too far into that bill because it's very, very complicated, more complicated than it probably needs to be, but we'll be dealing with that probably in January. It could be that so much time and attention is spent on the Affordable Care Act that maybe issues like this value-based purchasing go by the wayside, but that might just be wishful thinking. The Ways and Means Committee is pretty intent on working on this bill. Then we will see Medicaid reform. I'm going to give you a few more details on what I see working here on Medicaid reform. So you've heard about block grants. What exactly does that mean? Right now the Medicaid program is a jointly funded program by the feds, CMS, and the states. Feds put up about half the money, states match about half, and then the states administer the program. And that federal money comes with a lot of strings right now, a lot of rules, mandates, etc. And states don't like all those rules and mandates. And maybe in the last 10, 12, 13 years, states have been very active in seeking waivers. They seek CMS permission to waive a particular federal mandate and then operate their program, outside of that particular rule. That's become very popular, and that's why I mentioned earlier that the CMS designee has had a consulting company working on that issue because it's very popular for states to seek that. Okay, so getting back to what would the block grant kind of be, just looking at it very simply, right now Medicaid funding is to the states is rather open-ended, and that's one of the problems with it if you're looking at it from a critical point of view. And what a block grant would do, it would be a set dollar amount, a block of money, a set dollar amount that would be provided to each state, and there would be a whole formula with regard to that. And that state would receive that sum of money, and it might be less money than they are maybe receiving right now. And that doesn't sound like a good deal, but the governors perceive it as a very good deal because in return, they would receive less strings, less mandates, less rules on that Medicaid block grant, on that sum of money they'd be receiving, and they'd have more flexibility to operate their Medicaid program with that funding the way they want to, and customize it to their state citizens' needs. And that's, you will see in a phenomenal lobbying program from the governors to D.C. to do that. This issue could also come out in terms of per capita caps. What does that mean? Instead of one big sum of money sent to, say, Virginia, a formula could perhaps be worked out by saying, okay, Virginia has this many Medicaid enrollees and projects this many, in coming years, and there would be a dollar amount associated per enrollee, and the money going to, say, Virginia could be calculated per person and then sent to Virginia that way. It's just it's just different variations on a theme, right? Just different ways to send the money to the state and without strings or with fewer strings. And the states would like this very much. You will see a battle royale, I call it, on this. Consumer groups will fight it like crazy. Democrats will fight it like crazy. So what's the impact to us? Well, to our sector. Well, if you're working on the state level or you have Medicaid enrollees that are in your nursing facility or in your adult day or in your assisted living facility, you may know that within a particular Medicaid state budget, nursing facility care and home and community-based care is generally the largest piece of that state Medicaid budget. And in turn, in any state's budget, Medicaid is generally one of the top three consumers of the state budget. So Medicaid is a big deal for states, and it pays for a lot of long-term care services and supports. And any shrinking of that money or changing of the program could impact providers and patients. So that will be a big, high-profile fight next year, both Medicaid reform and the Affordable Care Act and any tentacles, as I call them, that it could have. Let's talk of Part B, Medicare. Let's go back to Medicare and talk Part B for a minute. I think this is going to be a lower profile issue in 2017, and that is the therapy cap. Let's talk rehab therapy for a moment. And, I've got a couple bullets on here on this slide just to kind of remind you of the current law, current statute, federal statute that we're under. The therapy cap for 2017 is $1,980 cap on occupational therapy and the same dollar cap on physical and speech-language pathology. We've got an exceptions process for patients that need therapy above the cap, and the issue is that exceptions process is in federal statute and always has a date, an expiration date attached to it, unfortunately, and that exceptions process does expire December 31st, 2017. So the question for Congress is, are you going to yet again, as they've done for many years, extend that exceptions process for what, maybe another year into 2018, Or will Congress really step up to the plate and repeal this irrational therapy cap? And in its place, Congress would want to establish some kind of process to control rehab therapy Part B spending. I wish they didn't have to, but they do feel like they do. Really don't know which way that's going to go in 2017. There's only so many staffers that work at the committees that deal with these issues, and their time and attention could really be pulled to Medicaid and Affordable Care Act. So when they do have a few minutes to spend talking to us groups about the therapy cap issue, it could, they might make a decision right away which way they want to go, and it could happen fast, meaning that any fix to Part B therapy could get rolled up into or included in any repeal, replace Affordable Care Act, or even maybe a Medicaid issue, just because those will be large, significant bills, most likely passing Congress. Now, that last bullet on the slide, it's just kind of some fun to think about a little bit. Congressional Review Act, what is that? That was a law passed by Congress in 1996, eons ago, right? But it allows Congress to overturn a regulation that an administration has promulgated in the last couple months of an administration. And there's quite a bit of criteria that regulation has to meet in order for it to be considered by Congress to repeal. It's only happened once in, I think it was 2000, 2001. For any folks that have been around a while, you may remember OSHA's ergonomics rule. Yeah, that one was overturned by Congress using the Congressional Review Act. Like I said, pretty high bar, but, there's lots of little trade press articles out there about, could our mega rule, be repealed by Congress? I think it's least likely, because that rule is all about patient safety, patient care quality, and I think it's less likely. But you know how folks like to kind of speculate a little bit, and it'll get a little talked about. So let's move a little bit. So I hope I haven't scared you too much with what Congress could do to us, or what we do need them to do to us in the terms of therapy. We need them to help us with that process. But let's think about the mega rule for just a minute. And my partner Todd is going to talk a little bit more about this at the end of the slides. But we do have the mega rule on us, the requirements for participation. Nursing facility operators already have to be implementing Phase 1 requirements, and we'll be soon receiving from CMS interpretive guidelines for many of those requirements. And then Phase 2 requirements will go into place towards the end of 2017, and we'll see Phase 3 requirements will be needed to be put in place by 2019. And so that will consume quite a bit of time for operators next year. In fact, they should have started already, really. What else is on the horizon for us? Well, the IMPACT Act is still going, right? It's still chugging along. It has a program within it called the SNF Quality Reporting Program, QRP. And the QRP is all about Section GG, right? The new section of the MDS, where we are collecting functional data, and that function data is going to inform, as I like to say, or populate the quality measure formulas that have been imposed on us by the IMPACT Act. So you're submitting that Section GG data now as an overall party or MDS. Compliance, and there's a little bit of a dollar amount attached to that, right? We have to comply with submitting Section GG data, and compliance is providers must submit all data necessary to calculate the SNF QRP measures on at least 80% of the MDS assessments. And if you're not compliant, you could lose 2% of your annual payment update. So what is Section GG really populating? It's helping calculate the one or more falls with major injury quality measure, patients with pressure ulcers that are new or worsened, and then, of course, patients with an admission and discharge functional assessment and a care plan that addresses function. It's very much a positive that we're moving into functional reporting because it's really going to, if these measures are right, it's really going to show the good things and the way we're really helping the patient. So there on the horizon, we have additional QRP measures that will be effective October 1, 2017. There will not, for these measures, discharge to community, Medicare spending per beneficiary, the ones you see on that slide, they will come off of, that data will come off of claims. So for these particular measures, you will not see new additions to the MDS. But we could get other measures in the April payment rule that could require new additions to the MDS. And that will be a theme, unfortunately, for the next couple years. What else is out there? Certainly 5-star continues, and as I'm sure all of you know, we had 6 new measures this year, and of course they're going to continue into next year. And I just wanted to highlight that 2 of the 6 new measures have to do with function. On the short-stay patient, improvement in function since admission and decline in mobility. Measures from the IMPACT Act or the QRP will eventually find their way to 5-star, as well as measures from PBJ are going to find their way to 5-star. Oh, I'm sorry, not exactly to 5-star, to the Nursing Home Compare, where the 5-star measures currently are reported. And Nursing Home Compare will be a place where consumers and others can see the results of all of our quality measures across all the programs. I'm going to move quickly on this slide. This is really just a reflection that it'll be interesting once Secretary-designee Price gets on the inside if some of his views on CMI and other programmatic changes continue once he's on the inside. He wanted to get rid of it while he was on the outside, but what will he want to do when he's on the inside? And he might want to take advantage of the cost savings that are being driven by that department. Now, given all that I've laid out here, what can you do to prepare? I think the most important piece on this slide is that provide the best care you can to your patients. Bottom line. Provide the best care, because that will see you through all of these quality measures that have been imposed upon us and will continue to be imposed upon us. Follow CMS activity as closely as possible. Another piece, be aware that some of the quality measures are in multiple programs, right? You see this readmissions measure is in the SNF QRP, it's in the SNF value-based purchasing program, it's in 5-star. It's not always the same measure, but it's all about reducing readmissions. So back to bullet number 1, provide the best care you can, which includes trying to reduce patients having to go back to the hospital, and you'll be okay on these quality measures. You'll shine. Another big takeaway I'd like to give you is develop your data story. I know you probably hear that over and over again, but your data story, what is your length of stay? What is your recidivism rate of your patients back to the hospital? What kind of key indicators are key about the patients you serve? What are your key core competencies? Develop that data story that you can share with hospital partners when they come calling to involve you in their bundled payment arrangements or when you have to make the case to them. And finally, identify your own partnerships. Don't wait for the hospital in your market to come calling to you. Think about downstream providers from you. If you're a nursing facility or assisted living, think about the home health agencies that serve your area. Could you go to them and present your data story and see if they want to partner with you as a ready-made solution for a hospital, maybe that wants to send their patients to SNF or maybe wants to bypass SNF and go right to home health, but together you've presented to that hospital some kind of value proposition and maybe those patients can continue to come to the SNF before home health. So take, your destiny into your own hands. At this point, I would like to turn it over to Todd. It's been a pleasure to be with you. We're going to have some Q&A at the end. But first, I now hand it over to Todd for some information about pharmacy as it relates to the mega rule. Take it away, Todd.
Thank you, Cynthia, and good afternoon, everybody. First of all, on behalf of Omnicare, I'd like to thank everyone for attending today, and also thank you, Cynthia, for your review of kind of what's ahead for CMS policy in the future. And I learned a lot, and it's got a lot of opportunities out there for us to kind of look at specific areas around where we can make sure that we're providing the highest level of care for our residents in our facilities. One of the things that I'd like to touch on just briefly is to kind of expand a little bit on what Cynthia said regarding the mega rule. And I've got a couple slides just to review over quickly before we break for Q&A, just to kind of go through some of the key areas from a pharmacy standpoint that we're seeing as an opportunity for facilities to look at specific areas that they can collaborate with their pharmacies to move some of the items in the mega rule forward. What I was going to do is just kind of talk about some of the medication-related changes in the mega rule. As Cynthia mentioned earlier, the mega rule is going to be implemented over a series of dates in the next few years. We're going to talk about specifically a couple items in Phase 1, which most of you are aware that Phase 1 went into effect November 28th of this year, just a week or so ago. So this is really kind of fresh news and things that we're looking at forward to move forward for medication-related changes. One of the things, and it's a couple of the items that are new that we won't touch on all of these just for time's sake, but I think it's good to touch base on a few of these that showed pretty significant changes with the mega rule. Just in some of the Phase 1 areas, definition of psychotropic drug, which we'll touch on that in just a second, the definition of irregularities and related changes and how they occur from a pharmacy standpoint, policies and procedures for the monthly drug regimen review, and then something that everybody has been focusing on is the development of a facility infection and prevention and control program, or antimicrobial stewardship, as you guys have been hearing all the information out there. Antimicrobial stewardship, and we'll touch on that just in a couple slides. And we know the importance of that. Antimicrobial stewardship will phase in all three phases of the mega rule rollout. So I think everybody's aware that when CMS published the original proposed rules for the mega rule, there was a period of time for comment. And several of you on the phone and on the webinar probably provided comments to CMS. One of the areas that we were, as a company and as pharmacy in general, were most concerned about was the definition of a psychotropic drug. Initially, CMS did pose that a psychotropic drug would include a variety of classes of medications, including opioid analgesics and other types of medications that may affect cognition. We did provide comments around that, and other pharmacy providers and other organizations did also, and CMS did define a psychoactive drug as specific categories that we're used to, the antipsychotics, anti-anxiety medications, antidepressants, and hypnotics, but did put a caveat in there that said that any drug that affects brain activities associated with mental processes and behavior would also be designated a psychotropic drug. This does open up for some interpretation on how these medications work, and I think will give us an opportunity to fine-tune our policies and procedures around the use of these drugs. The next slide just touches briefly on irregularities, and I threw this one in there just because I think it is an important change that involves a key member of our team in the long-term care facility, and that's the medical director. CMS did change in the mega rule the reporting of irregularities to include the medical director in addition to the attending physician and the director of nursing now should receive a copy of all the pharmacy irregularities on a monthly basis. So this procedural change does put a little bit more responsibility on the medical director to oversee the aspects of pharmaceutical care and drug utilization in the facility. So that is somewhat of a change for each of us, and will be something we'll look at down the road. Lastly, I want to touch briefly on the infection prevention and control program. this slide, as everyone knows, CMS and the CDC have really been pushing us in long-term care to look at antimicrobial use and antibiotic therapy. Each facility will be required to develop this infection control program going forward, and it will be phased in, as I mentioned, over the 3 phases of the mega rule phase-in. Why do we need antimicrobial stewardship? And we all know that that's to prevent antimicrobial resistance, and the inappropriate use of antimicrobial therapies can lead to these and makes it difficult in developing new antibiotics. The CDC has given us a variety of things that we can do as long-term care facilities to start this process, and that's starting an infection control team, identifying patterns, and streamlining empiric therapy. And that's something that each pharmacy will be working with their facilities going forward. Something that we can do now is depicted in this slide, and I'll finish up with this, is making sure that we can go ahead and start making sure that we have complete antibiotic orders, making sure they have a name, a strength, a dose, a route of administration, an indication, et cetera, are things that CMS is going to be looking forward in the future when they do surveys around the use of these medications. This last slide just goes over a couple other areas where their effective dates are in phase 2. This is care planning, psychoactive drugs regarding PRN use, and antimicrobial stewardship. So in closing, I'd like to just summarize a quick comments around some of the pharmacy services as we went over briefly: antimicrobial stewardship, the definition of an irregularity and how those are communicated to the physician, and also the definition of psychoactive medication, which was clarified by CMS in the most recent edition of the Mega Roll. With that, I would like to turn it back over to Pamela for questions and answers, and once again, appreciate everybody attending today.
Thanks so much, Todd. We appreciate it. Thanks again to Cynthia and Todd for such an informative presentation. We've already had several questions come in from the audience. If you would like to submit a question, there's plenty of time. Just click on the Q&A widget to the right of your slides to submit a question at any time. I just want to say we're having some difficulty with the CE button, so we'll have some different instructions for you at the end of the Q&A on how to apply for your CE certificate. All right, so we've had several questions come in about the block grants. So Cynthia, let's start there. One question says, if states receive block grants, we've also had questions about the pay cap, but for block grants specifically, could the state decide to divert that money to programs other than Medicaid?
No, they could not. That'd be a saving grace, I guess. No, that if it's Medicaid money being sent to the state, it has to be spent in the Medicaid program. Okay.
Sort of a related topic is some of the other things you mentioned as possible changes for Medicaid. With the possible alterations to Medicaid, how might that affect facilities that have a lot of residents who are dual eligibles, and how can they best prepare?
Sure. Okay, so a dual eligible is going to have Medicaid is paying for their room and board, and any services that they're receiving, like, Medicaid is paying for their nursing and their room and board and their food. But if they're receiving if a doctor has to come in and see them, or they're receiving some Part B therapy, that's going to be those doctor services and the therapy, or maybe an X-ray or a lab. That is all paid for by Medicare, and that's where you see the two programs paying for services because they're eligible for Medicaid, and then they're also eligible for the Medicare Part B program. So that's why they're a dual. What you would potentially see, and I'm going to speak very simply, because every state's going to handle it a little differently. You could see a state obtaining flexibility to loosen the requirements that are on them about who has to go into a nursing facility. There's been this so-called institutional bias in the rules, where patients have to go into a nursing facility or be eligible for going into a nursing facility before they can access maybe home and community-based services. And a lot of that changed with the old Olmstead Supreme Court decision, and, states have really taken a lot of great strides to increase the funding to their home and community-based services. But they would, in this bargain, states would receive more flexibility to change how they fund and what requirements are around what type of patients go to a nursing facility or are eligible for a nursing facility, and what kind of patients could receive home and community-based services. So that word diversion that was asked in the other question, from a negative point of view, you could see monies in a state diverted away from institutional care to fund more care in the home and in the community. That would be kind of a threat from the providers, the nursing facilities provider point of view.
Okay. Here's another question. Do we know when PBJ might be reflected on the nursing home compare?
Ooh, good question. No, I don't know officially. I could guess 2017, but I don't know 100%. I don't know officially. But let's think of it this way. They've got to get the kinks out of it first, right? We've just begun reporting. And they're not going to want to put it up publicly on Nursing Home Compare until it's, then the kinks have been worked out. So I don't think it'll be soon. I wouldn't see it, first quarter 2017. No, too early.
Okay. Another attendee writes, I know that much of this information discussed today pertains mostly to SNFs or skilled nursing. How might any of this affect assisted living communities?
Sure. I think generally speaking, with the Republicans in control of the House and the Senate, you won't see the big issue, the big gorilla or the white elephant, whatever you want to say, that's always out there for assisted living. Will the Congress seek to regulate from a federal point of view assisted living? And it's my opinion that let's say Clinton would have won the presidency, and if she would have won that, there was a good chance that the Senate would have flipped over to Democratic control. If that was the case, I would say that there's some senators on the Senate Aging Committee that would have then gained control of that committee, and maybe Senate Finance, that would be interested in regulation of assisted living. It's not something that would have happened right away, but, hearings would be scheduled and that issue would start to be bandied about. But think about Republicans' general point of view, less government, less regulation. So I don't see that coming in, that issue seeing the light of day during this Congress.
Okay. Todd, this question is for you. The listener says there are many medications that can affect brain activities and behavior as side effects. You said something about clarification of that definition. Is that already in effect? And if so, where can we find a list of those medications?
Yeah, that's a great question. When CMS first produced their guidance on the mega rule, they did have a very broad definition of psychoactive medication, and the comments actually were sent back suggested that we use specific medication categories that we know, and those were the 4 that I listed. And CMS also wanted us to look at producing a list of medications that can cause these symptoms in the elderly. And as you know, medications affect elderly residents very differently, so that category or list of medication would have been very difficult to produce. I think the way the rule reads right now, the way it's written, and it is in effect right now, is that as clinicians, we should be looking at any medication that can potentially cause side effects of the cognitive or CNS nature. So as certain drugs affect people differently, we need to be focusing on changing condition in those folks and how the medication changes and dosages affect them cognitively. But to provide a list would almost be impossible based on the way these medications work, the way they interact with folks. And so there's not a specific list. You will need to concentrate on the antipsychotics, the anti-anxiety, hypnotics, and antidepressants. But it can include any medication, and that can affect central nervous system activity. So I didn't really answer your question completely because we're going to have to look at each individual resident individually.
Got it.
Thank you.
All right, that's all the time we have for the questions today. I just want to say we're having trouble with the CE widget, so don't do it that way. I have some different instructions for you. What you'll need to do in order to get your CE certificate is you'll need to send an email. I'll give you the web address. It's webinars@vendomgrp.com. So the word webinars, the @ symbol, V as in Victor, E, N as in Nancy, D as in dog, O, M as in Mary, E, and then grp.com. And if you send an email, let us know. We know you've attended, and we will take care of your CE certificate for you. Please note that the CE credit is not available for the archive of this webinar. It's only available for this December 7 live event. If you have any trouble with the process, please don't reach out to anyone at Omnicare, our sponsors today, because they won't be able to help you. I'd like to thank Cynthia Morton and Todd King once again for an excellent presentation. So complicated, so much exciting things coming down the pipe for 2017. Also, I'd like to thank you and our audience for participating today, and we hope you'll join us again in the future for another iAsk webinar. This concludes today's presentation.